Recording in progress.
Right, welcome to Way to Basis, one of the free sessions. And today the discussion is about consenting for a procedure. And thank you, Dr. Armali, to be a candidate. And then I'll give you as an exam pattern. So I will time it first. 5 minutes, your time starts now. At the end of 5 minutes, we will start the scenario, okay? So I'll give you 5 minutes now. Your time starts now. The scenario is 70-year-old Michelle Carter presented with chest pain 2 weeks ago. CT coronary angiogram showed a significant lesion in her proximal left anterior descending artery. She was told by cardiology consultant that PCI, that is percutaneous coronary intervention, might be indicated. She was not keen, and you are seeing her today as a follow-up. Task is to explain that your recommendation is undergo PCI to treat her coronary artery disease. See, not only Dr. Almuli, I would suggest everyone to take notes and make this as a 5 minutes opportunity to see in terms of what you want to tell and what other questions patient might ask, what is this scenario about, and then you can discuss. So when the 5 minutes is over, we'll start the role play. Right, I did share the scenario in the chat. I think new people are joining, so I'm doing it again and again. See, this discussion or the role play, you can take it as a prototype for any procedures, counseling, consenting, anything you can do this as a prototype. And that's what we are aiming for. At the end of the session, you will know in terms of what are the things to ask, what is it, and what are the challenges, how to undergo those challenges, and then get the scenario done as smooth as possible. And I would say or request not to put anything on the chat when the role play is going on, because that would distract the candidate. Because I've seen that, and so many people told me as feedback. So if you say, for example, some other answers, or if I examiner asking questions and the role play, if you put something else, and people will get distracted and look at those. So you can hold everything until the end of the role play, and then at the end, either you can ask or you can do it in a chat. Thanks for your understanding. If I want to give a brief idea in terms of role play with this one, so first 5 minutes now as the exam is taking notes and then preparing what to tell, what not to tell, those kind of things. And then we'll start the scenario. The 12th minute, I'll warn him, 2 minutes left. And then winding up things and summarizing everything in the 2 minutes. Then I'll give him 1 minute to collect his thoughts, and then 5 minutes with the examiner. Then the feedback will be there and all the questions. Right, if you give me 1 more minute, I'll just try the YouTube live is not working. I'll just, because people who miss this can have a look later on, that's what I'm trying for. I'll see whether I can do something. Give me 1 more minute. Right, no worries. So it's not working. Right, your time starts now.
Shall I start, sir?
Hello? Yeah, start. Time started now. Yeah.
Okay. Hi, I am Dr. Ramesh, one of the doctor in the Cardiology Clinic.
Yeah,
Is this
hello.
Mrs. Michelle Carter I'm talking to?
Yeah, I'm Michelle. Yeah.
Okay. I come to know that you came today as a follow-up visit, and with your history, I came to know that you have chest pain 2 weeks ago.
Yeah, you're right.
So, and I want to take something about our conversation as a notes, and
Yeah.
it will be confidential.
Yeah, you can do, doctor.
Okay. What do you think about your problem?
I know because I had a chest pain and then they do some test actually. When they did them test, what they said was I may need a procedure actually. See, when I say procedure, something like a, what to say, something to get the release the block or narrow some tube or anything they said. So I'm not convinced about all those things. I'm really scared about going through any procedure because anything, say procedure related to heart is it's we all know it's a high risk and dangerous, isn't it? So I don't want to go through. That's what I said. I was not keen, and I even don't know why I'm here as a follow up because I said clearly I don't want to have the procedure, and I don't know. Give me some medication and I will go. See, I'm not like a very young as well. So I know my limitations. So I'm happy to have the medications and go.
Yeah, I can imagine your fear about the procedure. But before going for any decision, I want you to take a clear thing from my side. So I just need some time to explain about it.
Yeah,
So,
go on, doctor.
do you
Explain
think?
me. Let's see.
Do you think what the chest pain is due to?
Sorry.
Uh, why the chest pain happened to you? Do you have any idea?
I know they said some block going on, but you tell me, doctor.
Yes. Actually, the chest pain is due to yeah, some block in the blood vessel supplying the heart, your heart. So to relieve you from future chest pain, we have to remove the block by a procedure called percutaneous coronary intervention. So percutaneous coronary intervention means that such blood vessel has to be approached through the through the skin route. Skin route means we have to give a nick in the hand, so through which we will send a tube inside the blood vessel inside a blood vessel called radial artery, and we will advance it towards the heart. In the heart, we will approach the diseased vessel by injecting a dye, um, by which we can reach the blocked site. And at the blocked site, we will insert a ballooned stent, through which the balloon is inflated, by which the balloon is inflated, after which a stent is placed, and by which the block will be relieved. Do you understand it?
It looks like a long procedure and looks like a very complicated. You said the tube, balloon, these, that. Honestly, I can't understand clearly, but looks like a major procedure to me. Is it a major procedure?
It's it it can be between minor and major. Uh,
Right, between major and minor. So what do you call? Do you call it a medium procedure?
Not to the level of major risk.
Okay, right. So you told about the procedure. What are the risks involved?
Risks involved means if I don't think much risk is involved unless you have any other diseases.
Like what?
Like suppose if you are having some kidney disease, means there will be problem in giving a dye. And suppose if you are having some other heart diseases like any valvular heart diseases, then you may be at risk. Otherwise, no need to worry about that.
Okay,
So
look like I don't have any valve problems or I don't have any kidney problems. But you said in the kidney problem with the dye, so will the dye affect the kidney?
no, it's it won't affect the kidney. It is a temporary shutdown to the renal function. It will be recovered with treatment.
All right, that's a good news because that's one of the thing I was fearful actually. People told me, oh, they use some special chemical that will knock off your kidney completely and that's it. And people are talking in terms of dialysis and all. So that's what I was worried about first of all. So that's a little bit reassuring. But people have some major problems, isn't it? So when you do it, see, I'm thinking in terms of, let's say, for example, any normal procedure or any small surgery, if you do a nick and then take a, like, for example, take a bump out or anything like that. So that's outside in your hand or anything like that. But this, you're going inside the heart, isn't it? So heart is a major thing. You're talking about a major organ. So you may be doing it day in, day out. So for you, it's okay. For me, it's very scary. So what if the heart stops suddenly? What do you do? If the heart stops and people, I'm being open here. Do people die due to the procedure? Can people die?
Your heart is already diseased heart. We are trying to save it with this procedure.
Oh no, I'm asking, due to the procedure, while doing the procedure, is there a risk of death? I'm being open. I'm not worried about death. It's 70 years, so I will die at some point, but I don't want to die while doing this procedure.
The chances will be very minimal. It may be around a 10 to 20% chances will be there. Not more than 90% are like you are worried about.
Oh dear, 10 to 20 is a lot, isn't it? 10 to 1 in 10 will die then. That's a lot, I would say.
But practically, if this procedure is not done, means even in 6 months or 1 year, suppose if you are exercising more, or if you are hearing some stressful news, then you can land up in sudden cardiac death.
Oh dear, that's scary. Now you're scaring me actually. I don't know. I don't know what to do.
Not like that. I want to tell you what will happen if this procedure is not undergone.
Okay, right. Do I need to take any special medication for that if I undergo this procedure?
Uh, just before the procedure, we will give you some anticoagulants. Uh, Otherwise, no other drugs are essentially needed apart from your regular cardiac drugs.
Okay. So still I'm in a dilemma. So I'm just asking you, you explained your level best. You know, for you it's a day-to-day job and you're doing it. But can I say no? Still, can I still say no?
Yes, you can have you can exercise that option because we are not forcing you
Okay.
because it's your body, it's your health, and you have the right exercise the option whether
Okay.
to proceed with the procedure or whether to go for medical management.
Right.
That's up to you.
Okay. I'm still not very convinced about it actually. So when people say they don't want to have this procedure, and do you give any extra medication to cover the procedure? Because any other medication to cover the procedure, the same effect. Can any medication give the same effect?
Yeah, we can give medications, but it won't be 100% effective like this procedure.
So are you saying me
It
this
may
is
reach up
100%
to,
effective?
we can relieve a blocked vessel, but with the medications, the block will be relieved a little bit. It will be reduced gradually only.
Okay. So from your experience, tell me the block, because you told about the procedure, major, minor, medium. With my block, do you think from experience it's a major block or medium block? What would you say?
From your CT coronary angiogram report, it says it's a significant lesion, which
Right.
means the block would be more than 90%.
Okay. So are you telling me it's a major block then?
Yes.
Okay. Then it's a bit tricky. You said the major block, and then who will be 2 minutes more? Who will be doing the procedure? Or they say, I'm not. I mean, everyone is good at their job, I know, but are people good at their jobs in terms of who will be doing it? Will you be doing it?
I, our team with an anesthetist and interventional cardiologist and other supporting staffs will be doing the procedure, and the interventional cardiologist will do the thing.
Right. Okay. Now I'm slowly thinking whether to have it, and with the reassurance. Also, I'm still thinking whether to what's going on here. Okay. Right then. So we'll go ahead, and then I would, but I can change my mind anytime, isn't it? So let's say you give me a date for
Yes, sir.
Monday.
Yes, sir. Yes,
I can,
yes,
yeah.
yes. You can.
Okay. So you think I'm well enough? Being 70, I'm well enough. You think?
No, you are 70 years with a diseased heart with a significant lesion. So better thing from my side is you can undergo the procedure.
Okay. That's right. That's right. That's thank you, doctor. Thank you for taking your time, because I had lots of problems before in terms of what my concerns are, and then you try to reassure in your own experience. That's okay. Right. We'll go ahead, and then we'll take it from there. Thank you.
Okay. If you have more doubts, we can arrange one more meeting for clarifying your further any queries.
Yeah.
You can discuss with your family.
Okay.
and then you can plan your healthcare attorney.
What is that? What is that? Healthcare attorney. What is that?
Health healthcare attorney means if something like some bad thing happened to you, then at that time, if you are not in a position to take a decision, then your appointed person will take the decision.
Okay. The time is up. And this is a 1 minute time to collect your thoughts. And then we'll continue with the examiner time. And again, doctors who are listeners, you can also make a note, the 1 minute, what the examiner is going to ask and how you're going to answer. And again, giving a clue like what are the legal implications, what are the ethical implications. That's a standard question in any station 4. And yeah, time is up. Right, the examiner session starts now. Hello, doctor. Can you summarize the consultation for me, please?
Yes, sir. I in this consultation I was able to know the patient's understanding. Then I was able to explain the procedure, and she is able to understand and little bit convinced about the procedure.
Okay.
And I have reassured her that I will arrange one more meeting to clarify her further queries.
Well, do you think she will need one more meeting? Because she said to go ahead. Why do you think she will need one more meeting?
She is not like 100% willing to undergo the procedure, sir. That's why.
How do you know? Did she say that? How do you know she is not 100% sure? Did she say that?
No, sir. No, sir.
Okay. So you think you will need one more session with her?
Probably, sir.
Okay. And you said the possibility of death is 10%? Are you sure about the percentage?
I'm not sure, sir.
Not sure. And do you know any other complications? What are the complications? Or the
Arrhythmias can occur.
Then?
Dye-induced reactions.
Okay.
Any bleeding from the punctured side. Pain after the procedure.
Okay. Right. You're talking about PCI and a stent. What type of stent do you use?
So we will use the metallic stent.
Do you use anything else apart from metallic stent?
Bioprosthetic stent is also used.
Okay. When do you use this one and that one?
Sir, not audible, sir.
Sorry, did you say not sure? Okay. And she asked, do I need to take any special medications when I undergo this procedure? You said no.
Yes, sir. She
Are
asked.
you aware of any special
I
medications?
said. Anticoagulants will be given before the procedure.
Okay. How long will you need to be continuing that?
It will be continued 5 days after, till 5 days after the procedure.
Right. Sorry, you give anticoagulant and then that will be continued 5 days, discontinued 5 days after the procedure.
Yes, sir.
Right. What is the risk if the PCI is arranged as an emergency procedure? This is a planned one. Is there any
Yes, sir.
difference in risk between an emergency PCI and the planned PCI?
An emergency PCI, the risk of sudden death will be more.
Okay.
Come.
Right. What are the legal and ethical implications here? Right. Time is up.
Yes, sir.
Okay, now you can come off the candidate role and I'll come off the surrogate role and examiner role. Right, that's good, I would say. Say it's not bad. That's good, because I think the people who are listening don't know, because the three of them said they will be a candidate, but unfortunately no one turned up due to unforeseen circumstances. And then Dr. Almali was the first one to join, and I asked generally, and he offered to be the candidate. And for that one, it's absolutely fantastic, I would say. So first of all, he doesn't know he's going to be a candidate. Second, he doesn't know what he's going to discuss. No clue about the topic. Then it's like a sudden exam. But in PACES, it's not going to be there. You will get a months and months of planning and weeks, and even the last few days, you practice 1,000 times and it will be more easier. And that's why, see, if you ask in terms of surrogate level and examiner level, I didn't pitch to the highest top level because I know the difficulty, and that's how the exam would be. The questions would be like a top level. They'll pitch in the right level, and then depending upon our answers, they can increase the level higher and higher. Generally, people say if we are experiencing more difficult questions, that means we are doing well. Not worry about the most complex question and then we didn't answer that. Not worry about that. That means you're doing very well. The basics we have done and the next level we have done. So my feedback is, for the doing for the first time with me, you might have done with many people many times, but with me for the first time, without any warning, without any like a timing with the procedure, that's brilliant. But obviously there are certain things to improve. I would say we need to know the fact clearly. I don't think it's 10%. 10% is too much. 10%, that means people won't come and do the procedure. So it's less than 1% actually. Less than 1% is a death or a stroke. That we need to look into this. Not only this procedure, any procedure we need to know. Or else we can say, see, average you can say, but you can't quote a wrong figure. You can say, I don't know the exact percentage, but in my opinion, it's not something like a major effect or anything like that. And when I talk about the major, you said is the major or minor, you said in between. It's okay, but there isn't any term like that. You can say that. See, what makes major or what makes minor generally? When it involves a death, that people call it a major actually. Major means death or serious side effects. And when the percentage of serious side effects and the risk of death is higher and higher, it will be classed as a major. But when the risk of death is lesser and lesser and the serious side effects are less, it's not a major. Say, let's say endoscopy. Do you call that as a major procedure? No. It's not a major procedure. But again, this one, you can, but the death rate is higher. But it's when compared to coronary artery bypass surgery, this is not the bigger one. But what you have told is correct. So people are not going to say that is wrong. What you have told is correct. And I will appreciate that, because rather than asking major and minor and then confusing the patient, you conveyed the message clearly in a layman language to explain the patient. I'm encouraging you and everyone, you can do that. As long as you attain what you wanted to achieve, you can do that. But in general, you can ask, you can return the question. Say anything if we struggle, if you don't know, you can just return the question. So what is your understanding about major procedure? You can ask. And then she will say, oh, the risk of death and major. And then you can say, yes, I'm not going to lie to you. There's no risk of death here, but it is only less than 1%. So if you take that as a procedure, I would say it's not major. See, before explaining, because you assumed major as something, whenever we are in doubt, just ask the surrogate or the patient and they will tell us, what do you mean by major? I'm just checking your understanding. So it's not like you're telling, I don't know what is major, I'm asking you. You're not going to do that. So what you're telling is, I know what is major, but I just want to know rather than assuming and then understanding. That's the way I would say. And you told the complications to the examiner neatly in terms of pain and puncture site and arrhythmias. So ideally, you have to tell all those to the patient as well. Ideally speaking. So you let's say like you discuss only part of the complications and then left the other. But from a patient needs everything. And most of the time patients are worried about pain. If you say the pain is not a problem, that's okay. And then the other thing is patients will ask, do I need to stay in the hospital or can I, it's a day procedure, or can I go get the procedure and go home? Those are the two top questions people will ask with any procedure. First thing about pain. Second thing, do I need to be admitted to the hospital or can I go home the same day? And usual steps, risk, side effects, benefits and things. And you explain the benefits clearly in terms of if you don't do it. And he said little bit, you need to change your, like a phrase, because you said directly in terms of if you don't do it, kind of, I get it, like if you don't do it, you will die. Oh dear. But you didn't mean that. You didn't mean that. I know what you're trying to say is, say even without the procedure, there is a high risk, but with the procedure, we are helping. That's what you're trying to say, but you can change the phrase, because as a surrogate, it looks like if you don't do it, like a teacher attitude or the parents, the kid attitude, paternal attitude, it was like that. But I didn't give you any trouble for doing that. I just commented and then went off. But if we do that in the exam, we'll be caught. They'll suddenly go into anger mode and then say, oh, you telling me I'm going to die without that and you're scaring me, blah, 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 everything. And then we'll be anxious. Because I know the anxiety within you, and then I didn't pitch to that level, but just in terms of, and that's what it happens. See, that's what in exam, when somebody asks a question, immediately you need to answer without, say, including everyone, without thinking we say something. Are you telling me I'm going to die? And then immediately you would say, yes. No, that's not the way to answer. Because when a patient is asking in a faster mode, we tend to answer in a faster mode. When a patient is increasing his or her voice, we tend to increase our voice. But we shouldn't do that. We should need to be exactly opposite. When they are talking fast, we need to be talking slow. Not dead slow, but slow. And when they are raising their voice, we need to calm down. Like then only the medium will come. This is not angry situation. This is quite common actually. It's very common situation, quite calm. Everything is fine. But I'm just telling you in terms of any situation, this is what it is. And legal ethical implications, do you know? Are you aware of any legal ethical implications? No? Anyone else? Anyone else? Legal ethical implications in this scenario or any scenario where you're doing a consent for the procedure?
Consent. Hello.
Yeah.
Driving.
Yeah.
Yeah. So the executive device brings the autonomy
Autonomy. Yeah.
and beneficials.
Okay, then you have to explain what is autonomy.
Yeah. Okay, so autonomy, this gentleman has the right to know about his medical condition and the management plan, and he has the right to accept or decline the management plan after full explanation.
Okay.
And Percutaneous is doing this for him by going for BCI, which is the test management of his condition.
Yeah.
And non-malpractice avoid the complication by doing the procedure by the most expert doctor and like sterilization and all precautions to avoid the complication. And the illegal issue may be the consent here, since this patient has the capacity and he is accept the procedure, he have to sign the consent.
Okay. Yeah.
Yeah.
That's right. Yeah. Anyone else? Yeah, that's right. So legal and ethical. Legal is always the mental capacity is there, and then consent or anything. See, I would say in every situations the mental capacity comes into play. Whatever the scenario in station 4, whatever you do, like dealing with angry patients or consent or confidentiality or anything, the mental capacity comes into play. And for that, again, for Dr. Arul, like candidate, I would suggest you to get the summarizing. See, you said she's not sure and you think she's not sure, even though she said, okay, go ahead. Then you can ask, that's the summarizing is the main key to check their mental capacity, what's their understanding. So every procedure you have to ask at the end in terms of, okay, we have gone through all these things. Can you summarize for me to check my understanding whether we have discussed correctly or not, something like that. And then a patient will say. So in this situation, patient will say, okay, I was very fearful initially and you explained about this. Now I know the severity of the condition. So if I don't do it, equally the risks are there. And if I do it, the risks are there. But in your experience, you don't think that will come under high risk. So as a balance, I understand I need to go for the procedure and you're doing good for me. I agree with you, doctor. That's what it says. So if the patient or surrogate says that, you know exactly the patient has a mental capacity, and that means you got the information and the information synced in, weighs against the pros and cons and made a concrete decision about this. Equally, patient can tell exactly opposite. I know you're trying a level best to explain me, blah, 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 everything A to Z, but still I don't want to go through. I am ready to take the risk of not doing the procedure. I know there are risks if I'm not doing the procedure, still I don't want to do it. See, that is why summarizing is the key skill in station 4 in any stations. But you can ask me if it's a very rough and hard station, how can you ask the patient to summarize? There are some exceptions, but if you can't summarize during the patient session, you can tell the examiner in terms of, say, due to time constraint, I was unable to do the summarizing, but if I have a good time, I would have summarized. I would have summarized, and I would have asked the patient to summarize the discussion for me. Then that means, because that point is a tick point in terms of marks. So I'm not, when I say tick, it's not a tick exercise. That's a well-known, experienced, excellent practical experience to do it. Summarizing and then asking the patient to check the understanding. Because in here, what it was like the candidate told everything and the patient told everything, but in no way you can go back and check. And that's why he felt the patient is not keen. He's right. The candidate is not, even though the surrogate said, okay, I'll go ahead. It's not a straightforward yes. It's like there's a little bit of doubt in there. But instead of assuming, if you go ahead and ask in terms of summarizing or tell me what we discussed, then there'll be a clear tick and you can go with the confidence to say yes or no. So legally, the first thing is the mental capacity comes into play. Again, consent is there. And when you talk about mental capacity, you have to tell about refusal. If the patient refuses, you can tell this patient has a mental capacity and people have a right to refuse the treatment as long as they understand the pros and cons, and we need to respect her. We can't do a procedure and we will treat her with the medications as much as we can. That's it. And with the ethical, you're right. Autonomy will comes in exactly the same. They have a right to ask about the treatment, right to know about, but they have a right to refuse as well. But any people, they don't have a right to demand any treatment. Beneficence, yes, doing good. We are doing good. As a whole, yes, risk and benefits there, but the benefits outweigh the risk, and so that we are recommending the procedure to the patient. Non-maleficence, again, we are not doing any harm. If you don't do any procedure, that might do more harm to the patient. Doing a procedure will help us overall. Yes, there are harmful effects in terms of procedure per se, but what we are telling is in this situation, we are very well experienced. There's a less risk, and then we were able to cover. So for minimal things like kidney problems and things, we have got a plan to how to reverse it, even though it's a temporary thing. And the last one is justice. Sorry, when we talk about justice, it's mainly the resources, keeping the good resources and treating people fairly and things. So here she's 70, you're not going to tell, oh, you're 70, so I won't give the procedure to you. That doesn't matter. Whether 50 or 60 or 70, if that procedure is helpful, we are going to give. That's about being fair and treating everyone equal. And people might talk about resources. So when you talk about resources, it's not 100% relevant here, but you can tell in terms of why we are not wasting the resource by giving the PCI for this lady, because it's very, very helpful, and we are not denying the same procedure for anyone else. So it's being fair, being equitable, and getting the resources spread across equal, and not being judgmental. Those comes under justice. That's all I would say. Right, any questions from the candidate first, Dr. Arulmozhi, and then anyone else?
No questions, sir.
Sorry? No questions. Right, can anyone know the risk of the procedure in terms of percentages? PCI.
Acute kidney.
What? Acute kidney.
Yeah, doctor. There is a lot of Ramesh.
Oh, hello.
How are you?
I'm fine, thank you.
Thank you, Professor.
Yeah, tell me.
So the risk of procedure from the start, there could be failure of the procedure itself, or there may be bleeding from the side, injury to the surroundings, infection on the side of the person. It could be due to the contrast that is injected, the patient may have anaphylactic reaction or some low blood pressure, skin rashes. It is not common, but the incidence is low. This may be provoked to acute kidney injury, contrast-induced nephropathy.
Yeah, okay. See, I would say, yes, the risks are there. People won't argue with that. But if you can specify a little bit more, that would be helpful. Say, let's say, for example, we are talking about the serious complications. And when you talk about, you can just like conclude serious complications or minor complications. If we talk about serious complications, less than 2%, if you say as a whole. Less than 1% is the death or the stroke, and then 1 to 2% they can have a serious bleeding, and less than 1% damage to the artery in the arm or leg while do the procedure. And there is also less than less than 1% sudden blockage in the major coronary artery, because if you do one thing and then the other the leftover can get blocked, and they may need like emergency CABG. So that's what you said in terms of failure of the procedure. When you say failure, one is yes, you can't do it. Two is you can't do it, but not the procedure, but the things are making worse. You need to do something. So you can mention about the emergency CABG here. Yes, kidney damage is there, but the candidate rightly said it can be reversible, and sometimes they may need a hemodialysis. And the dye allergic reaction, it's possible. Say, I'm not telling everything to scare people, but these things you will tell in detail about, because and then at the end of the day, people can't say you have not told me that and things. And the most important thing is a the symptoms can return actually at the end. So yes, we are trying our best, but symptoms can return, and that's why it's only 5% people some symptoms can return, and they may need a repeat procedure. And candidate told about abnormal rhythm, that's about less than 0.5 percentage. So in terms of percentage, you no need to know in all the procedures all the percentage like this, but if you know it, you can tell them. That will be more, what to say, like a consoling and for the patient, because they want to know that. They don't want the general statement. Mostly they won't have any problems, and majority of the time people will be okay. They don't want that. If I were a patient, I want to know exactly what is what. Either you can tell, or you can tell, I don't know the exact figure, but I will find out and come back and tell you. So you can't close the question like, I don't know the exact figure, but in my opinion, majority of the people are okay. You can't tell like that in exam. If they ask specifically what's the percentage, you can say, I don't know at this point of time, but I will go back, find out, and come and tell you exactly, precisely what is available.
Yeah.
Any other questions? Right, I will summarize. See, I'm summarizing, so that's the that's the whole point of any discussion. See, in terms of consent for a procedure, so I would say what are the points needed to be borne in mind. First of all, PCI and where to start. See, sometimes people start with okay, complaints of chest pain. How are you doing? And how is your chest pain? So where do you get chest pain? How long? How is it? I don't think that's absolutely needed here, because you can jump to the task, and candidate did the right thing. And that's where reading the scenario helps. And Dr. Almoli said clearly in terms of, okay, I came to know you had a chest pain, you had the test, and test show this. I'm here to talk about the procedure called PCI. That's it, very clear. Having said that, there are some situations you can ask some history, but I'll come to that in a minute. When you talk about complications, let's say for example you're going to talk about the dye and then the kidney functions. So in those situations you can generally ask like a one line. I want to check whether you had any other problems with the kidney. If it is there, you need to be extra cautious. If it is not there, it's a straight tick. And she told, I don't have any kidney problems. But what I'm trying to say is, whenever you get any procedure, there will be history. Let's say endoscopy with the GI bleeding, or anything like a cystoscopy with the hematuria, and kind of any procedures. So you need to be careful not to trap in history taking and then do the whole history for 2 minutes. And patient will patiently answer all those questions, but we don't have time. So the first thing is where to stop the discussion. We need to be very, very clear in that. And that is why I always find useful and suggest you to go through the scenario and read the scenario with the patient, so that you can pitch where the conversation is going to start. Then the next is, what is the procedure? In this situation, PCA means what? And that everyone will know. Any procedure we know. It's a camera test, and then a guide wire, a small tube, make a nick going in there, and we are doing S, X, Y, Z. That's okay. I'm not going to go into details today. And he has said that. Why PCI? That's another important thing. And that's the link with the scenario. Why 50% of the answer is in the scenario itself, why you are doing it. But you have to explain, and he explained it. If you don't do it, and things is going to get worse. And sometimes, see, at the moment, you have angina and the chest pain that settle. But if we don't do it, sometimes people can have a heart attack. And you can tell that. You're not scaring people by telling that. You're telling the truth. And that's why you're worried about, isn't it? So why do you do PCI? Because things can worsen. Can have a major heart attack. And then when they have a heart attack like a MI, and even survival is a question. Some people can die with a major heart attack. That's why you're doing a PCI. So why you're doing a PCI need to be explained in a simple way and clearly. And next thing about the procedure, as I said, whenever people ask about procedure, they are most worried about the pain. That's the most important thing. And some people are very sensitive. They say like, I'm very sensitive. My pain threshold is very low. So what do you do? And again, you can say, so we treat individually, and then we will take care of the pain. And we do this all the time. So our team will take care, and you can reassure them. Then the benefits. Benefits and the reason are closely related. Why you're doing PCI and the benefits are closely related. You can tell under any title, but you have to tell. Risk, procedure related risk, general risk, and that's where now come in terms of whether asking history in terms of any other medical conditions, and then the like a diabetes. Diabetes means the risk of infection there, and then the healing might take a bit longer. And the CKD, the patient has CKD means the die and things over there. So you need to do everything methodically. That's the structure we need to have in our hand. Where to start the discussion, why PCI, what is PCI, and I also add any other options. See, when you say any other options, what will happen if you don't do PCI? And that patient will ask, and patient asks in terms of, can you do medications as effective as PCI? And the answer is, there won't be anything as effective as PCI, and that's why we are recommending to you. And about the procedure, pain, and where's the procedure, what is the balloon, what is the stent, benefits, risk, and answering any question. This is our side. And in terms of stent, I would like to add, because candidate said only metal stent. Yes, it is a metal stent, but with the medication, without one. With the medication means it's a drug-eluting stent. We add some special drug to prevent narrowing. And when we give those drugs, we will need to give medication like a clopidogrel. There's a clear-cut plan is there. So if you're doing metal stent, it's not for life. Clopidogrel, you can stop with after 1 month. But if you're doing a drug-eluting stent, you have to give for lifelong. So that's why I ask in terms of, Dr. Ramesh, that's why I ask in terms of how long will you give. But I think you may not be aware at this point of time, that's okay. And that's why I didn't probe at the time. So you need to be, this is what I meant to say in terms of procedure related history. Any bleeding disorders, you can ask. Nobody is going to say, it's not history taking, but you're asking a relevant question related to procedure. But in what way asking about chest pain and then do you feel dizzy or shortness of breath is going to affect anything over there? It's not actually, because that, assuming that has been done and assessed, and after that, the symptom analysis, you tell a patient, this is what the procedure you are going to undergo. So in that case, our discussion should start from the procedure and not going back from the history. People easily fall into the trap, and that's why I'm repeating this again and again. And this is our part, like a doctor's part, in terms of what are the things we need to tell. At the same time, we need to work around the patient's part as well, or the surrogate part. And what do they think? Why are they? And repeatedly she is telling, I am fearful. So why is that? What is the fear about? Has any family undergone this procedure and any problems they face? Has any of their friends undergone this procedure? So you can ask straightly in terms of, that's where we say something, patient says something, and we meet somewhere in the middle. What are the concerns? What are the beliefs? And why are they telling that? Any experience they've got? And then only you can slowly hinge on. See, the mere medical explanation won't convince people. They have something different. We need to break that. We need to break that belief, because they are telling from their experience. We know, we have read all those things, we have got a training, we've got experience. So it's our duty to inform. It's not like you don't know anything, I know everything. It's not that attitude. It's our duty to explain what we know to the patient. Then only they can make an informed decision about what is what. So that's what I would say about the consent for procedure, and you can imply this in any situations. Right, any questions before we close? Okay, right, no questions. See, and then legal and ethical implications I've said, but you can see the other videos. There are plenty of videos in Facebook as well as in the YouTube. YouTube is not plenty, only 3 there. And in the Facebook, there are plenty. So you can have a look. I've discussed about how to approach legal and ethical implications in station 4, and about the confidentiality. And this will be like a consent and mental capacity and everything. So have a look and then ask me any questions. If you are following the YouTube, just you can put it in the comment or any means. I would say, see, Way to Faces is available everywhere. It's like a YouTube, Facebook, Twitter, Instagram, WhatsApp groups, and people can know my WhatsApp number, so you can directly text me in terms of this is what I want you to discuss. And the topics and things I'm selecting only based upon the feedback. I'm not telling whatever I know. So I'm only choosing the topics what people ask me. So let's say, for example, people ask me palliative care, end of life, yes. Dealing with angry patient, yes. Confidentiality, particularly HIV and things, yes. And this one as well, consent for the procedure, we have not done for a long time, and people said, I want to know exactly the structure and things. We did it. And station 5 mini sessions. So I would ask you to go through all the videos and then familiarize with the structure first of all, and when you practice, follow the same structure, then it will be straightforward. Right, if there are no questions from anyone, we'll close the session. Once again, thank you, Dr. Arulmali, for volunteering in the last minute and doing well. Thank you. Best wishes, everyone. Oh, right. Sorry, somebody's asking. Right, able to get an idea about the consent for procedure. Thank you. That's okay. And what is the name of the YouTube channel? The YouTube channel is Way to Paces. As the title says, Way to Paces. I'll see whether I would send the link. Are you in any of the WhatsApp groups? Are you in any of the WhatsApp groups? No. Oh, right. Right. I will put my number here. Right. You WhatsApp me, and then I'll join you to the group. Okay. Who another person not in the WhatsApp group? So again, if you're on the Facebook, you can go to the Way to Paces YouTube channel. Yes, Way to Paces. And again, you can follow in Twitter, Instagram, everything. But if you want as a closed group, yes, come in the WhatsApp group. And I've given my number. Please note down the number and contact me. I'll add you on. And there'll be regular free sessions. And the topics is based upon your queries actually. Oh, what? Not seeing the number, please. What do you mean? Sorry. Can you talk? When you say what seeing the number, what?
I can't see the number.
Oh, is it? Sorry, I'll repeat that again. Yep. Can you see now? I think it went to the waiting room. The icon was selected wrong. So now we should be okay. Have we got the number now? Yep, that's okay. Right, okay, thank you. So please feel free to ask any questions. And I'm also planning to do a question answer session, and that will be released soon. And I've got loads of questions already. See, this question answer session is only like a question and answer. It's not like a full scenario related thing. So if you ask in terms of, for example, how do you assess mental capacity, I'll tell that and then close it. So if you want any specific answer, not going into detail, you can ask me, and then I'll pick those questions, and then I'm doing it as a series. I've not released yet, so I'm doing it as a series. Only question, answer, like for example, like less than 5 minutes or 4 minutes, something like that. Just a question and answer, question, answer. Any topic, anything you can ask. Station 5, station 2, even 1, 3, 5, we can ask. 1, 2, 3, 4, 5, anything. But you have to be specific in asking questions. See, I can't discuss the whole scenario. If you ask in terms of how do you assess the confidentiality, it's very difficult to discuss. When do you refer people to palliative care, end of life care? It's a broad area. What are the ethical implications? That's a broad area. They have to do a free session. If you have got a specific question, I'll answer those. Already I've got loads, and then I'll release one by one soon. Okay, thank you. Bye-bye. See you the next free session. Best wishes. Take care.